welcome you all this afternoon for an exciting program on the antimicrobial therapy of respiratory infectious diseases. And it's my great pleasure to have my friend Dr. Chaideep Chowdhury from Kolkata. And we will be discussing minutest points of the management of the respiratory tract infections. Though the title is antibiotic therapy, remember it is the antimicrobial therapy, because last time we saw about the respiratory infections and the approach to respiratory infections. And we have seen that not only bacteria, but the viruses and the fungi and others also can attack the respiratory system. And it is important that we know everything right from the nose to the lungs. That is number one. Number two is that there is a concept of what is called as antibiotic stewardship. And I'm sure Jaideep will refer to it in the course of his talk. And the word steward particularly means rakhwala. Rakhwala is the caretaker. You know, many times we go to the five-star hotels and we see a tall person standing outside and welcoming everyone. He is the steward. He is the person who sees that everything which is proper goes inside and which is improper does not go inside. So antibiotic stewardship basically is a concept which is getting a lot of ground, wherein we will definitely use antibiotics when necessary and not use antibiotics when not necessary. It does not mean that we will never use antibiotics, because quite a few of our friends who are promoters of rational therapy, many times, they restrict the use of antibiotics to such a great extent that many times, even if the antibiotics are necessary, they are worried when they give antibiotics. That should not happen. When they are necessary, they should be given. Of course, when they are not necessary, they should not be given. And today we will discuss the antimicrobial therapy of all the respiratory infections. Many times it so happens that a child comes to us for cold, cough, and fever. And in a busy OPD, many of us, without thinking, land up in prescribing some antibiotic. Even if the child has viral infection, the child receives an antibiotic, which is a sorry state of affairs. And that's why we would like to make many things clear. Some of these are called as empirical therapy. Whenever the child is having fever, cold, and cough, we usually wait for 2 or 3 days. We really find out whether it is viral or whether the infection is becoming bacterial, and then we go on to give antibiotics. Okay, but there are some indications where maybe on day 1 itself we would give antibiotics, and then that would be an empirical antibiotic therapy. So we will also have a look into what are these situations. Okay, so I will just request Jaideep to start with his presentation. After his presentation, we will have a summing up of his presentation, and then we will go ahead and have question and answers from the audience. Thank you.
Thank you, Dr. Jog, and thank you, Microlabs, for taking this initiative. Now, Dr. Jog is an icon when it comes to delivering lectures, and he really is the guru when it comes to delivering lecture, and always a crusader of rational antibiotic therapy. I would try to do justice to the responsibility that has been bestowed on me. But it's a huge responsibility. It's a big chapter in any pediatric textbook or textbook of infectious disease. So may not be, I may not do the justice of covering everything, but I will try to make it interesting with few case scenarios. So when we talk about antibiotic, am I visible? Hello?
Yes, you are visible. Your slides are also visible.
Oh, no. Suddenly it showed the screen time sharing stopped. That's why I was wondering.
Maybe you can re-share. You can share again.
Is it okay?
Yeah. Now you can make it on full screen.
Yeah, it's full screen.
I think you'll have to click the full screen icon.
Wait, just again, I'll do it. One second. Both are 5-year-olds. One is having fever for 2 days with a lot of cough, sneeze, and throat pain. But the child is running around and well in between the febrile episodes. The other child, who is also 5-year-old, has fever 2 days, but severe throat pain. There is tender cervical lymphadenopathy, and there is not much cough. So when we approach these two children, we examine the throat to come to a possible etiology. The child on the left, who has more of cough cold, had this type of throat on examination, and the child on the right, who had more throat pain, cervical lymphadenopathy, you see there is exudates in the tonsil. The left one, there is just a patch, but the right picture you can see there is some exudates in the tonsil. So in all probability, the left one is having a viral illness and the right one is having a bacterial illness. Now, a child who is looking ill has palatal petechiae with inflamed tonsils, tender cervical lymph nodes. Some circumoral pallor and sandpaper-like rash may also be present, is typically a bacterial infection, most likely a group A strepto. Now, the group A strepto usually present with sudden onset of sore throat, generally in the age group of 5 to 15 years, with headache, sometimes nausea, vomiting. There is tonsillopharyngeal inflammation, patchy palatal petechiae. There may be cervical adenitis, which is tender, and sometimes scarlatiform rash. On the other hand, the viral infections usually have a multi-system involvement like conjunctivitis and diarrhea, along with cough and coryza. Usually the cough is more. There may be some hoarseness of voice, and there is discrete ulcerative stomatitis and viral exanthem also. So these are general clinical differentiation, but to establish the diagnosis of group A streptopharyngitis, we need some investigations above clinical features like swabbing the throat and testing for group A strepto by rapid antigen, which is often difficult and culture often not possible to do routinely. So what we can do, we can resort to the modified MAC-ISAC decision rule, where points are given for high fever, more than 100, no cough, 1 point, tender lymphadenopathy, 1 point, tonsillar exudates, 1 point. Of course, the age group 3 to 14 years carries 1 point. So if we total the points, then our clinical decision becomes easier. If it's 4, then we can treat empirically. 3, definitely we have to test for it, and or if our clinical judgment dictates, then also we can treat it empirically. But if there is 2 point, then we have to do the rapid strep test, then only treat, and 0 and 1 doesn't require treatment. Probably it's a viral. So while Dr. Jog has given the responsibility of thinking before inking, so we have to think a bit before writing an antibiotic. So by this, the commonest case that we encounter in our OPD, the upper respiratory infection, if we think, then we can come to a diagnosis whether it's a viral or bacterial. And if we are convinced enough that it's a bacterial infection, then only we go for treatment. The first line, without penicillin allergy, we know that it is amoxicillin is the drug. When there is no penicillin allergy, it's 50 milligram per kg per day, either once or twice daily, maximum 1 grams per day for 10 days, mind you, is the duration, is the general recommendation. Now, if the child is allergic to penicillin, then only we can go to antibiotics like cephalexin, cefadroxil, clindamycin. Regarding azithro, clarithrol, we will come to it later in our discussion. A 10-month-old healthy boy having cough and cold fever of high fever, 102 for 2 days. On day 5, he becomes fussy and wakes up crying multiple times at night. And when the child is crying at night, the parents can't sleep. And of course, as a retaliation, the doctors also can't sleep peacefully. So we receive multiple calls, and often they visit us with a complaint that the child is crying at night. But a child who is having fever, cough and cold, followed by fussiness, crying at night, is probably having a pain in the ear. As a routine, we must do an otoscopy. It is always advisable to do an otoscopy. The left one is the normal eardrum. You can see the umbo clearly and the tympanic membrane, but the right One is due to the effusion where the tympanic membrane is bulged. This is an acute otitis media. Well, we know that it's often very difficult to examine the ear of a child, but definitely if it's an acute otitis media, we have to treat it. Now, again, before we ink an antibiotic, what we can do is we can stratify and we can judge depending on severity, laterality, and age. The severity may be severe otalgia, otalgia lasting for more than 48 hours, or temperature 102 degree or more. This is severity. These are all severe symptoms. Laterality, if it's unilateral or bilateral, and age less than 2 and above 2. Based on this, we can frame the antibiotic guideline. Now, if you see any child with severe acute otitis media, be it unilateral or bilateral, severe, we have already come to know, severe otalgia, more than 48 hours, high fever. So we give antibiotic irrespective of age. Bilateral acute otitis media without otorrhea. If it's below 2 years, we give antibiotic. Bilateral acute otitis media without otorrhea, below 2 years, antibiotics. Above 2 years, we wait and watch. How long? Now, if after 48 hours, the symptoms persist, then we start antibiotics. When it's come to unilateral acute otitis media without otorrhea, then above 6 months, we wait and watch for 48 hours. Below 6 months, antibiotics. So any otitis media below 6 months, we treat with antibiotics. Any severe acute otitis media, be it unilateral or bilateral, any age, we treat with antibiotics. Rest, we wait and we do accordingly. But if otorrhea is due to acute otitis media, then we must start antibiotics irrespective of severity and age. So if otorrhea is there, then it definitely warrants antibiotics. Now, how do we select whether we go for amoxicillin clavulanate, amoxicillin, cefixime, azithromycin, and so on and so forth? So what should be our next step? Next step is, what are the common causes of acute otitis media? The commonest is Streptococcus pneumoniae. Second common is non-typable H. influenzae, and the next comes the Moraxella catarrhalis. Now, as an organism, streptopneumoniae responds well to amoxicillin, and that also usually in the usual dosage. But when it comes to H. influenzae, then probably we might need addition of clavulanic acid, because the resistance to streptopneumoniae, resistance to the mechanism of resistance of streptopneumoniae to amoxicillin is by alteration of penicillin binding protein. But for the H. influenzae, it is the enzyme induced. So if we add clavulanic acid, the beta lactamase inhibitor, then it will cover H. influenzae also. But for streptopneumoniae, it's only amoxicillin is sufficient, because there the beta lactamase is not the factor. So if we zero down on this, the organisms causing acute otitis media, our choice of antibiotics limits to either amoxicillin or amoxicillin clavulanate, never cefixime, because cefixime is a very broad spectrum antibiotic and mainly covers the gram negative. And of course, azithromycin is not required. Again, there are resistance to azithromycin, and azithromycin has other better indications. So when do we give plain amoxicillin? If the child has not received antibiotic in the past 30 days, or the child does not have concurrent purulent conjunctivitis, or the child is not allergic to penicillin. Dose is 40 to 50 milligram for 10 days. When do we give amoxicillin clavulanic acid? Definitely if the child has received antibiotic in the last 30 days, or the child has concurrent purulent conjunctivitis, history of recurrent acute otitis media, which was unresponsive to amoxicillin, then the dose should be 80 to 90 milligram per kg per day for 10 days. Regarding the second line drugs, well, cefodoxime, ceftriaxone if the child is admitted, levofloxacin if it's penicillin allergy, non-type type 1 reaction, cefdinide type 1 reaction only warrants macrolide or quinolone. A 3-year-old child 5 days fever up to 103 degrees, started initially with watery runny nose, which is now thicker, whitish discharge. Cough has never been a predominant symptom, febrile and toxic. This is acute bacterial rhinosinusitis. Now, again, this child needs treatment because this is the discharge is purulent. So again, amoxicillin. Second line is amoxicillin clavulanate, duration 10 days or 7 days after resolution of symptom. Azithromycin no longer indicated high degree of resistance. Now, again, amoxicillin clavulanate, in this case, when do we definitely give? If there is preceding history of antibiotic treatment in last 1 to 3 months. If there is history of daycare attendance or play school attendance of the child, children less than 2 years and children who fail to respond to amoxicillin within 72 hours, definitely we can escalate to amoxicillin clavulanate combination. 4-year-old boy came to OPD with fever for the last 5 days with respiratory catarrh, developed respiratory distress since morning, febrile child, there is tachypnea, subcostal retraction, saturation low in room air. Would you like to manage in OPD or admit? Now, there is nothing empiric in it. There are based on some fixed recommendation, like if the child needs admission, if the oxygen saturation is less than 92, not feeding well, signs of dehydration, tachypnea as per the age criteria is there, apnea or grunting is there, difficulty in breathing, or if there is risk of inappropriate observation or supervision at home, the child has to be admitted. Now, this child, this was the X-ray. Of course, this is a low-birth pneumonia, and most likely these are community-acquired pneumonia. Again, when we face one community-acquired pneumonia, first step that we have to think of the age-related pathogen. In 0 to 3 months, it's usually gram-negative organism like E. coli, Klebsiella, chlamydia, etc., and viruses. 3 months to 5 years, 1/3 of the cases are virus. Next comes streptopneumonia, H. influenzae, streptopygen, staph, rarely mycoplasma. Above 5 years, well, again, streptopneumonia is number 1, but mycoplasma jumps to the second spot and the rest follows. So again, the commonest target for us is streptopneumonia and H. influenzae. So pneumococcus is the most frequent foe for us, and we have to tackle pneumococcus. So while dealing with pneumococcus, we have to choose the right antibiotic. So what are the consideration? Probable organism, age of the child, severity of illness, immunization status, because with widespread Hib immunization, the Hib infection has come down, history of recent illness, hospitalization or antibiotic use, and of course, local epidemiological data and resistance pattern, if available, this is ideal. So when we choose an antibiotic, it's important to consider the concentration achieved at the site must be above the minimum inhibitory concentration. It's a microbiological criteria, difficult to detect clinically, but we have to follow certain guidelines. So minimum inhibitory concentration is the concentration of the drug, minimum level of the drug at which it can prevent the multiplication of the concerned bacteria. So when we talk about minimum inhibitory concentration, this is the minimum inhibitory concentration, and the drug level achieved must be above the minimum inhibitory concentration at the particular site, because it varies if it's in mid layer, if it's in blood, if it's in CSF, depending on the penetration of the drug, and the tight endothelium prevents the entry of the drug. Now, though it's important to have a peak level of the drug above minimum inhibitory concentration, but for killing the bacteria, more important is the time duration that the antibiotic is above the minimum inhibitory concentration. Ideally, the antibiotic must be above the minimum inhibitory concentration for half the duration between the 2 doses. Then only it can kill the bacteria effectively. So how do we treat non-severe pneumonia based on this guideline? Now, community-acquired pneumonia below 3 months of age, there is no question of outpatient treatment, it's a hospitalization. 3 months to 5 years, we can go for outpatient treatment. First line amoxicillin, second line amoxicillin clavulanic acid or cefuroxime. Above 5 years, amoxicillin, but here due to the atypical organisms predominance, we can go for macrolide or doxycycline as a second line drug. Now, if there is penicillin hypersensitivity, non-type 1, cefdinid, cefotaxime, but type 1, we have to go to the other group of antibiotics like levofloxacin, clindamycin or macrolide. If it's a severe pneumonia, now severe pneumonia less than 3 months, first line is cefotaxime or ceftriaxone. Second line, we may add aminoglycoside because gram-negative infection more common. 3 months to 5 years, first line either coamoxiclav or ampicillin. Second line coamoxiclav, cefotaxime or ceftriaxone. Above 5 years, ampicillin again, if it's available as a monotherapy, or coamoxiclav or macrolide as second line, cefotaxime or ceftriaxone or macrolide. But if staph infection is suspected, then cefuroxime or coamoxiclav or IV third generation cephalosporin plus clots as second line, vancomycin. Duration of therapy is very important. Non-severe infection, oral therapy 5 to 7 days. Severe pneumonia, parenteral followed by oral 5 to 7 days. If we have to resort to second line antibiotic, definitely parenteral 7 to 10 days. But if it's a staphylococcal pneumonia, then antibiotics should be given for 2 to 3 weeks, and a complicated pneumonia, parenteral antibiotics for 4 to 6 weeks. Because again, we must be rational, but if we give the duration less than the recommended, then there is always chance of complication. Staph pneumonia, ceftriaxone alone is an inferior choice if the child is admitted. Here, cefazolin, clox, coamoxiclav, cefuroxime for non-ICU methicillin sensitive staph aureus, or if it's a MRSA, then go for vancomycin or teicoplanin. When we are not sure the child is sick, better to initially start with both MSSA and MRSA coverage. Then as we get the report, we can scale it down. Now we started with our case with lower pneumonia. After a few hours, the hemoglobin was 9.5, WBC high, CRP high. You see this chest X-ray, very bad chest X-ray as the child admitted. So ceftriaxone was started and blood culture sent. But after 48 hours, the child was maintaining saturation with oxygen, but was still high temperature and dyspneic. So vancomycin was added to ceftriaxone empirically because this child was not responding and the X-ray was bad. Even after 4 days, the patient still running high temperature, dyspneic, hemoglobin low, total count high, CRP still higher. The resident visited microbiology department and the blood culture was showing methicillin resistant staph aureus. The final report was due. So we were treating with ceftriaxone and vancomycin, but the X-ray is still bad and there was significant amount of thick fluid with fibrin stands on USG chest. So a tap was done, pleural fluid, more than 1,000 polymorphs, glucose low, LDH high. So VATS was done, a chest drain was placed. And you can see here the chest drain is in situ and the child's condition was still critical. The culture report came, it was staph aureus resistant to oxacillin, coamoxiclav, sensitive to vancomycin. But so this is MRSA, but we are treating this child with vancomycin. Still the child is not responding. So what could be the cause? No improvement even after 2 days. Distress continuing. Total count has come down, but the CRP is higher. Neutrophil is higher and X-ray chest is still bad. So what to do? What could be the cause? Now, this might be a case of PVL producing staph aureus. Panton valentine leukocidine is an enzyme which is sometimes produced by staph aureus. And here the drug is clindamycin, which inhibits the toxin production. So if we are suspecting PVL, if a staph infection is not responding, if we do not give clindamycin, then again we are irrational in our practice. So here the drug of choice is clindamycin. So the child was put on vanco and clinda and showed gradual improvement and the child recovered. So here comes a higher antibiotic, but the rationality and base for it. So when should we suspect PVL producing staph? Airway bleeding, hemoptysis, hypotension, flu-like illness, gram-positive cocci on gram stain of sputum, X-ray multilobular infiltrate, and raised serum creatinine kinase. This might be some pointers for detection of PVL. A 5-year-old child, fever and mild cough for 10 days, received low-dose azithromycin outside, a very common treatment. Pain in the right side of the chest for 2 days. There is reduced oral intake, breathing difficulty, high fever, saturation low, tachypnea is there. So the child was admitted. The blood test was hemoglobin 10.7, WBC 15,000, CRP very high. And this, you can see the serial chest X-ray. USG chest was done. There was minimal effusion and consolidation also. So the child was started on IV ceftriaxone. The day 2 fever spikes continued. Oral intake was better, saturation 95%. Repeat USG on day 3 showed the pockets of fluid around 30 cc. USG guided tap was done. Then sent for gram stain and other tests, including ADA and gene expert, everything. But considering the continued severity, vancomycin was added. Day 5, fever spike reduced, symptomatically better, oral intake improved. The child started running around the walls, and the culture of the pleural fluid grew streptopneumonia sensitive to all antibiotics. So this was a methicillin, this was not a resistant organism. So definitely the vancomycin has to be omitted. So this is de-escalation. So if the child is critical, if the child is not responding, we may of course escalate. But at a later stage, if we isolate the organism which is sensitive to the initial antibiotic, then of course we can de-escalate. If we do not de-escalate, then it leads us to a far more graver situation. So graver situations are the acute unresolved pneumonia. So if we encounter acute unresolved pneumonia, how do we approach it? What could be the causes of acute unresolved pneumonia? We are treating, but it's not resolving. The child is deteriorating. We have to think of bad omen. B for bronchiectasis or influenza B. A for abscess, aspiration, influenza A. D for drug resistant or delayed drug, including steroid therapy. O for opportunistic infection like fungal infection, anaerobic, and of course HIV. M for misdiagnosis, non-infection. There is so many infection mimics we have to remember. E for empyema, eosinophilic pneumonia, embolism, and N for nosocomial and neoplasm. So bad omen leads to acute unresolved pneumonia. We move on to our last child, 5-month-old baby boy, fever and cough and cold for 20 days. The child was hospitalized twice, mind you, hospitalized twice, received multiple antibiotics, condition deteriorated, 1 episode of convulsion. In investigations done outside before admission was normal count and CRP, and this was the chest X-ray on admission. The child was drowsy, responding to painful stimuli, constricted pupil, tachycardia, BP 102/68 in a 5-month-old baby, respiratory rate 60, saturation 100% with 4-liter oxygen, the soft hepatomegaly, ceftriaxone was started. On day 2, condition deteriorated. Distress increased, saturation was falling, BP was becoming low. So the child was intubated, ventilated, inotropes and sedatives added, as you can see. Now, meropenem and vanco, the ceftriaxone was converted to meropenem and vanco as the condition deteriorated. The total count and CRP was high. Sudden desaturation with decreased air entry. So a wide bore needle was inserted and water seal chest drainage was given. Now the bacterial growth grew carbapenemase resistant Klebsiella pneumoniae. You see the history. It's a 20-day-old history of 2 admissions, multiple antibiotics. We do not know the rationality, and we do not know the duration and the dosage of the antibiotic also. Now this child has come up with a Klebsiella pneumoniae, and most commonly these are hospital acquired infections. So which antibiotic to give now? It's a carbapenemase resistant Klebsiella pneumoniae. So IV colistin was added, no improvement of inflammatory markers, fever was persisting, inotrope requirements was there, chest X-ray showed further deterioration, so bronchoalveolar lavage was sent. It's a complicated pneumonia. So any other organism, anything we are missing? Now, bronchoalveolar lavage showed a very grave picture, heavy growth of pan-resistant Klebsiella pneumoniae, which was resistant to BL-BLI combination, resistant to carbapenem, which we were giving, colistin, which we were giving, and polymyxin B. Now we have lost most of the armamentarium. We have very little choice with us. So treatment options for a multi-drug resistant Klebsiella or Acinetobacter, there is no consensus. Some opinion is polixin or polymyxin, tigecycline or fosfomycin, minocycline or doxycycline. Then recommendation of double carbapenem, meropenem and doripenem, or meropenem and fosfomycin, but nothing is foolproof. This is a grave situation. We are also looking forward to newer BL-BLI combination, ceftazidime, avibactam, meropenem, verbobactam, and even astrionam avibactam is being investigated in India. Most common carbapenems in India is the NDM and OXA. So Klebsiella, with this, we have very little choice of antibiotics. We are looking forward to this, but these are also not easy to get and treat also. The child was started on empiric fosfomycin and tigecycline because these were the few options we had. Luckily showed gradual improvement, extubated after 11 days. And for the next 24 hours, the child was shifted to HDU with mother, and now you can see the child is sitting and well. So what's the message? We must be rational in antibiotics. Definitely, we must think before inking an antibiotic, whether it's viral or bacterial. We must be rational in starting antibiotic, escalate if needed, de-escalate when the situation demands, but definitely we must be very judicious. Otherwise, we will land up in such a mess as this child. Luckily, this child survived. That's why I'm presenting this case, because this is a positive ending that the child is surviving and the child is well. But it's a luck share because we had very few choice of antibiotics. So I must end before Dr. Jog comes and tells, "Bahut ho gaya bhai, ab bas karo." Thank you. Thank you so much.
Thank you, Jaideep. It was an excellent presentation, and it was very crisp and brief. And all our colleagues got a lot of information about management of acute tonsillopharyngitis, then the management of otitis media, acute bacterial rhinosinusitis. Also, you mentioned about the non-severe pneumonia, the severe pneumonia, the staphylococcal pneumonia, and the non-resolving pneumonias. And moreover, you mentioned about the minimum inhibitory concentration, which is necessary for killing the bacteria. And also, you gave glimpses of a child who has had a severe respiratory infection. Now, I must say that most of these points, which are covered by Jaideep, I usually would like to put them in a small little short form in the form of a rational therapy. So where all the alphabets of this word rational would give you the gist of what Jaideep said. So R would stand for right dose, right route, and right duration. He also mentioned about the duration. For example, staph. He has mentioned that staph usually needs treatment for 2 to 3 weeks. So that right duration is important. A stands for academically updated decisions. You should know that the child who comes to you maybe in the age of infancy, usually you should consider different kinds of organisms. We know that Staphylococcus is common in the infancy, while as the age advances, the organisms differ. So academically, you should be updated so that you know what are the organisms affecting a particular age. For example, HIV child with pneumonia, we always think of the pneumocystis jirovecii and so on and so forth. Whenever a child comes to you with viral presentation and becomes breathless, of course, many times we discuss about flu coming, in a different way. And many times we are unable to differentiate whether it is viral or bacterial. But then we know that oseltamivir, when given early, will be helpful for this particular child. Many times we do not have any clue whether it is viral or bacterial. So academically, you have to have the decisions properly with academic updation. Then in that word rational, I would say that T stands for training of the mind. Whenever you get the involvement, now Jaideep already told you that the involvement could be related to the tonsillopharyngeal area or the sinuses or the middle ear or the lungs. So you should know that the organisms are there, but one particular organ, that is O from the organ, will be affected by the organism, that is another O, and then there is an option for that. Okay, so for staph the options are different, and for pneumococcus the options are different, and that is why the organ, organism and the option are important. For example, in general, meningitis, we know that it could be because of pneumococcus or Neisseria meningitis. Osteomyelitis usually is because of either Staph aureus or Streptococcus pyogenes, and pneumonias or respiratory infections are because of the usual three dangerous organisms, the pneumococcus, H. flu, and moraxella. So the knowledge is very important, and that is the basis of the antibiotic therapy. So right dose, right route, right duration, academically updated decisions, training of the mind about the organ, organism, and the options. I stands for instructions being given to the parents. For example, how to prepare amoxicillin, how to prepare amoxiclav. By the way, Jaideep also mentioned about amoxicillin, amoxiclav, and amoxicillin in higher doses, and what are the indications. That's also something important, and we all must remember that if there are some indications where the child has received amoxicillin in the last 3 months, or if the child is attending a daycare, many times it's possible that the child is resistant, and then we need to give a higher or a different kind of antibiotic therapy. Then the O in the word rational stands for organism and the search for organism. Okay, so you can use different ways of searching the organisms. Most common, of course, is and the ideal most is the culture, but maybe it's not always possible. So we have to have indirect clues either from the complete blood count or the other tests or the X-rays or the biofire, which is used these days. Okay, and then we can also remember about N. N stands for noting down the diagnosis. I always like to tell my students and residents that you note down diagnosis. If you write down that it's viral, then your hands will shake when you really write amoxicillin, because on the top you have written viral and at the bottom you are writing an antibiotic. So you should note down the diagnosis. Of course, many times it's difficult to understand what's going on, and many times I end up writing IDK, and that is I don't know, or GOK, that is God only knows. But for many days I used to write this, and then the nursing staff in the hospital said Dr. Jog is writing always IDK or GOK. So I had to change the short form, and now I write DUR, that is diagnosis under revision. Okay, so only that's between you and me, so that our staff doesn't know what I'm writing anyway. So that is about the noting down of the diagnosis. A stands for audit in the hospital. Wherever you are working, there is going to be some flora of the microbes, either in the NICU, PICU, or in the pediatric wards. And it's always prudent and wise to take the samples for culture from different places in consultation with the microbiology department as well as the pharmacology department. And the alphabet L from the word rational stands for locket of the patient. Remember that patients coming to us are either poor or from the middle class or from the rich class. But then where you can use amoxicillin, which will cost somewhere around 40 or 50 rupees, you need not use amoxiclav. For example, when you are using for simple tonsillopharyngitis, amoxiclav costs almost 3 times more. And that's why you have to look at the locket of the patient. These are some of the ethical issues. We will be discussing more about the need for amoxiclav in the subsequent programs. But I think we must be rational to the greatest extent as much as possible. And with this, we have some of our listeners asking some questions. And then, Jaideep, there is a question from our colleague who wants to know as to, in case if a child has HIV pneumonia, what is the line of treatment? So do you have any inputs on that?
Yeah, HIV pneumonia, we have to treat by cotrimoxazole. That is the drug which is normally, as you have said, it's due to pneumocystis jirovecii. It has to be treated with cotrimoxazole. That's in proper doses. That is 10 milligram per kg of trimethoprim that we have to stick to it. And there we should not fiddle with any other antibiotic because it won't work.
Okay. There is another listener who wants to know as to when a child is brought to the hospital in a breathless state and we are unable to find out as to what is the causative organism. do we start using antibiotics upfront simply because the child is serious, or what should be the line of action? A breathless child with high fever, is it possible to differentiate viral or bacterial, and what should be the line of action?
As per the definition of pneumonia, any child who is running fever and tachypnea is clinically diagnosed pneumonia. So we can defer X-ray, but if we diagnose the child is having tachypnea as per the age cutoff and of course running fever, then we are justified in starting antibiotics. If later it turns out to be not a case of pneumonia, or the child has become afebrile, the X-ray doesn't show a lobar pneumonia, or the child is having only wheeze, then we can definitely, viral wheeze maybe, then we can definitely stop antibiotic. That will be rational. But a sick child coming to the emergency, breathless, fever, tachypnea, antibiotics is warranted.
Right. And there is another listener who wants to know whether we should add oseltamivir in such children who are breathless and where diagnosis is not possible.
Oseltamivir, well, it depends on few factors. Oseltamivir is, of course, not the first line of treatment. The first line is an antibiotic. If it's an admitted child, it's usually ceftriaxone or coamoxiclav or ampicillin. Only if the child is not responding, if the child has some features which might point towards a viral infection or is having influenza-like illness, if possible, we may do a viral test, but maybe from the nasopharyngeal swab, or if possible from a bronchoalveolar lavage also, to establish a diagnosis of influenza. But if a child is definitely not responding to antibiotic with other features suggestive of a viral infection, then it warrants to start oseltamivir, not as a first line therapy.
Right, right. And Dr. Shrikant wants to know as to what is the management of COVID pneumonia.
Well, COVID pneumonia is a totally different entity now. I mean, it has been proven that none of these antibiotics or say antivirals do wonders in COVID pneumonia. So more of supportive care with an antibiotic cover is definitely warranted, because over the last 2 years, it has been proven that none of the antivirals that were started were curative against COVID pneumonia. Rather, supportive treatment, and of course with an antibiotic cover, is indicated.
Okay. And then Dr. Abdul Qasim wants to know as to how to treat Acinetobacter pneumonia in ICU settings.
Acinetobacter, we definitely need to go up to other antibiotics. Now, Klebsiella, Acinetobacter, usually we may try, hopefully it will be sensitive, but we may try with some carbapenem, and hopefully these are sensitive. But Acinetobacter, if it's not proven, then there is no question of starting empiric treatment, thinking of it's an Acinetobacter. If it's proven, better to go for the sensitivity pattern.
Okay. And then one of the listeners wants to know as to when a child is brought to the hospital, usually he is put on IV fluids and ceftriaxone. And the recommendations are saying that it is amoxicillin to be given. So what is to be done by a general pediatrician who is running a hospital, where many times he is under the impression that IV ceftriaxone is the drug of choice to be started? So what should a general pediatrician do when a child comes with pneumonia?
Ceftriaxone is a broad spectrum antibiotic. If we are not sure whether it's a meningitis or it's a typhoid fever or it's a pneumonia, so pending confirmation of the diagnosis, we may start a broad spectrum antibiotic like ceftriaxone. But if we are certain on admission then it is a pneumonia, then definitely we can start on amoxicillin or coamoxiclav or ampicillin as first line treatment. But if it's other infections like typhoid or meningitis, then definitely for a broad coverage, ceftriaxone is indicated.
Okay, so all these questions which were posted by our listeners have been covered. Now, Surekha, if you have any other questions in your chat box, please let us know so that we can discuss them and thrash out right here.